My name is Johnny Garcia, a third-year dermatology resident of Universidad del Valle, a member of the third Glodermanti cohort, and a researcher at CDIM. I have been conducting syphilis research in Cali, Colombia, in South America over the last 7 years, and it's my honor to present diagnostic issues and challenges in syphilis. So I don't have any conflict of interest for this talk, and this presentation is for the Guinea World Skin Day 2025. The first challenge I want to discuss with you today is that the clinical manifestations of syphilis are diverse and may be subtle, and that may difficult the diagnosis. So syphilis is a chronic systemic infection that is caused by the spirochete Treponema pallidum subspecies pallidum. This disease can be transmitted through the contact with infectious fluids. It could be vertically from mother to child or horizontally, mainly through sexual intercourse. So at the site of sexual exposure, the first manifestation is an ulcer. This ulcer may solve spontaneously without treatment, and after a few weeks, fluids. The systemic manifestation vertically from mother to child. It is characterized by skin manifestations, mucous lesions, and systemic disease. These lesions also solve spontaneously without treatment, and the patient enters a latent period that is known as early latency. So during early latency, the patients may develop recurrent episodes of secondary syphilis, up to 25% of the patients, and it could be during the first few years of the infection. After this, the patient are completely asymptomatic during latent syphilis. However, they are infected, and without treatment, up to 30% of the patients may develop complications. In the cardiovascular system, the central nervous system, the eyes or the ears. However, I want to remind you that the neurologic manifestations of syphilis can be present at any stage of the infection. So this is an infection that is very, very infectious, and only 57 spirochetes on average are required to establish the infection. The incubation period lasts in average 21 days, and after this period, on the site of sexual exposure, a single or multiple ulcers may appear. These ulcers may be small, less than half a centimeter, or large, even more than 3 centimeters. These ulcers may be painful or may be painless. They are more likely to be painful if they are around the perianal regions or within the anal. So in men who have sex with women, the lesion usually is on the penis or the oral cavity, and men who has sex with men, depending on the sexual practices, it could be in the rectum, the oral cavity, or the penis, and in women, it could be in the vulva, cervix, oral cavity, or the rectum, depending on the sexual practices. As I said, this ulcer may be asymptomatic and it may solve spontaneously. So these are some examples: as a very small ulcer in the frenulum of the penis, another small ulcer on the lower mucosal lip, a patient with multiple ulcers, and a woman with 2 ulcers on the labia majora. An ulcer on the perianal region, and this primary syphilis, it could be a very superficial lesion like an erosion, or it could be a very destructive ulcer, as in the bottom image. So after a few weeks, of the resolution of the chancre, the manifestation of secondary syphilis appears. So, however, in up to 25% of the patients, particularly in people living with HIV, there may be an overlap between primary and secondary syphilis. So the skin manifestation and systemic manifestations of secondary syphilis are present in addition to the chancre. So the skin lesions can be of any morphology, but traditionally 40% of the patients may have palmoplantar involvement. This is a systemic disease, so the patient may have fever, lymphadenopathy, hepatitis, glomerulonephritis, uveitis, periostitis, arthritis, and neurologic symptoms of early neurosyphilis. So these are some examples of secondary syphilis with lesions on the palms, the soles, and the maculopapular rash on the trunk of two different patients. This rash may compromise or may affect a large proportion of the surface of the body, or it could have very subtle and sparse lesions. Another examples, so as I said, this could be of any morphology, in this case with psoriasiform lesions, alopecia, and genital lesions like the condyloma latum, and in the oral cavity a mucous patch. Another examples of secondary syphilis from our studies, a patient with ulcerative plaques on the skin, and another patient who has a mucous patch on the inferior part of the tongue. The alopecia associated with syphilis traditionally is in patches, like in these examples. However, it could be a diffuse alopecia. So this alopecia in patches is known as moth-eaten alopecia. So up to 60% of patients with primary and secondary syphilis may be unaware of the lesions, and they may not consult or go to the clinic. So if the patient don't go to the clinic, this makes the diagnosis even more difficult. The diagnosis of syphilis depends on the direct detection of the spirochete or its antigens, and the most employed direct test is PCR that detect the DNA of the spirochete. Indirect tests detect the immune response of the host to the spirochete. So we detect the antibodies produced during the infection. They could be treponemal, non-treponemal, and most of the rapid tests are indirect tests. So serologic tests could be treponemal or non-treponemal. Treponemal tests detect antibodies against the proteins of the spirochete. They are positive for life, as you can see in this graph, and they can be developed during other trypanomatosis. Since they are positive for life, they cannot be used as a marker of therapeutic response or to the diagnosis of reinfections. Non-treponemal tests, on the other hand, detect antibodies against lipid antigens of the spirochete or the host that rise during the infection. So these antibodies are expected to reduce their titers after treatment. However, this clearance of the antibodies could be slow, particularly, for example, in people living with HIV, in patients who has an excess of the antibodies, since these tests are based on agglutination. When we have an excess of antibodies, the excess of antibodies impair the agglutination process, and therefore the test will be negative in spite of being a true positive. So that is a false negative due to proson effect. The zero fast status is that around 10% of the patients don't their titers after treatment don't reduce as expected. So they remain positive and are relatively high titer than expected in spite of being cured and after receiving effective treatment. These tests may detect antibodies that are produced during other infections like uh, leprosy, for example, or uh, or autoimmune disease like lupus or during neoplasm. And these antibodies also rise in other in other treponematosis like Pegel or Pinta, and therefore neither treponemal or non-treponemal test can differentiate syphilis from other treponematosis. This table highlights the sensitivity of a serologic test for primary syphilis, and you can see that most serologic tests for syphilis have a low sensitivity for this stage. Therefore, for screening, the recommendation is to use algorithms. So the traditional algorithm starts with a non-treponemal test, which positive results are confirmed with a treponemal test, and the reverse algorithm starts with a treponemal test that is on immunoassay, which positive results are confirmed with a non-treponemal test. And you can see that we highlighted the likely interpretation because we cannot be sure with certainty that we are diagnosing syphilis or that we are excluding syphilis. We are likely interpreting these results as possible syphilis or a possible absence of syphilis. So there are scenarios, for example, a negative non-treponemal test could be present in due to the Proson effect, a very late syphilis, or a patient with a very early syphilis before seroconversion. A negative treponemal test could be also a very early syphilis case. So the interpretation is difficult. And both tests could be positive after treatment. So a patient that develops a reinfection after a short period of time, the diagnosis may be difficult because these tests both are positive. Rapid tests can be performed at the point of care and therefore they may reduce the time to treatment, but sensitivity of this test is very variable with a pool estimated sensitivity of 85%. So most rapid tests are treponemal in nature, but some rapid tests may detect both treponemal and non-treponemal antibodies, and even there are some cassettes for rapid tests that can detect other infections like HIV and hepatitis C or hepatitis B. We have done some studies and we have found that the sensitivity of rapid tests in people living with HIV is good. So the overall sensitivity was over 94%, but we identified several sources of heterogeneity in the sensitivity of this test. And we found that the sensitivity was lower for patients in patients that were not using antiretroviral therapy, in patients who had high titers or high viral loads, and in patients that were tested by one of the operators who had difficulties getting enough blood for the test. So there are biological and uh, operational sources of heterogeneity, and this may be taken into account during the interpretation of rapid tests. The screening of syphilis is recommended for high-risk groups. However, we had found also in our studies that in Cali, about half of patients living with HIV and approximately 70% of transgender women have positive results for treponemal test. And this is important because that means that we cannot use this test for these populations. So we only have the non-treponemal test. But we also have found that there is a high variability in the results of non-treponemal tests. So this plot is the difference in dilutions of two different kits of RPR performed at a reference laboratory with the same sample versus the mean value of the RPR in dilution. And if this test was perfect, all these results will be around zero. However, these lines mark the maximum agreement that is allowable, that is one dilution above or one dilution below, because more than one dilution is two or more, and less than one dilution is two or less than two, and that have a therapeutic implication. So at two or more dilutions above means a potential reinfections, and two or less dilutions below means a potential cure. And we found that between two different kids, 10% of the results had a difference of at least two dilutions. And this is important. But even more important than this is that when we compare the results of the same kid performed with the same sample at an outpatient clinic and the reference laboratory, 50% of the results were more than two dilutions above or below. So these have very important implications, particularly for health systems like the Colombian health system, where we often don't have access to prior RPR results, or where the follow-up RPR test for may be performed at other laboratories. So the interpretation of these tests becomes very, very difficult. Molecular tests aren't perfect either. So the sensitivity of these tests is relatively good for primary syphilis, but is lower for other stages. So in a study that was conducted in Australia, they found that the overall positivity of PCR in early syphilis was 61%. It was 91% in primary syphilis, 74% in secondary syphilis, but only 8% of the patients with early latent syphilis had a positive PCR. Colleagues in China have developed a novel PCR that uses CRISPR-Cas technology, and this CRISPR-Cas designed PCR has a higher positivity, particularly, for example, in whole blood compared to TACMAN PCR, that is the standard PCR. However, the implementation of a CRISPR-Cas based PCR is expensive, is technically difficult, and at the moment is not available for most centers. So in the future, if there is a way to convert a CRISPR-Cas based molecular test in a point of care molecular test, we may have a very sensitive molecular test for the diagnosis of syphilis. So the overarching lesson of these examples is the diagnosing repeated infection with the current available diagnostic test can be extremely challenging particularly in our health systems. And delayed and missed cases of syphilis have individual and population level consequences. At the individual level, we may have complications like eye and ear involvement, meningeal syphilis, meningovascular disease, general paresis or tabes dorsalis. We may have cardiovascular complications that has a potential for disability, and the gumatose disease is supposed to be a benign disease. If these gumatose lesions appears in the central nervous system, so may have severe complications. As the incidence of syphilis increase in the general population, it also increase in pregnant women. And during pregnancy, if untreated, it could lead to abortion, stillbirth, neonatal disease, and prematurity. And the neonatal disease could have severe neurologic complications in the neonates. Also, it is very difficult to identify neonates who are asymptomatic and who may benefit from treatment. So that is also a complication of getting a syphilis during pregnancy. So novel syphilis tests are urgently needed. So these tests need to detect all the stages of the disease, must be able to differentiate treated and untreated diseases for monitoring therapeutic response, and also to differentiate the serophase status. And for neonates, they might be able to identify asymptomatic neonates who may benefit from treatment. So in conclusion, clinicians should be aware of the diverse manifestations of syphilis. The interpretation of diagnostic tests is challenging, particularly for repeated infection, and novel tests are urgently needed. My syphilis research journey has been funded by the Wellcome Trust, the NIAID, the Fogarty International Center, and strategic funds from Connecticut Children's. I would like to say thank you to my colleagues at University of Connecticut, Dr. Riddles, Dr. Salazar, and Dr. Howley, and one of my mentors at University of Oxford, Dr. Adrian Smith. Also to my colleagues at CDAIM, the Clinical and Community Research Unit, because without them, I wouldn't be able to do the research that I have been done. And finally, I want to say thank you also to Dr. Niraj Paranjuli, my Glother mentor, who encouraged me to give this presentation. Thank you very much.
Good day, everyone. My name is Dr. Folakemi Cole Adefe. I'm a consultant physician and dermatologist at the Lagos State University Teaching Hospital in Lagos, Nigeria, and I'm also a Gloderm mentee. I'm very happy and honored to be presenting at this year's Guinea World Skin Health Day Congress, and I'm going to be talking about resistant fungal skin infections and possible links to topical steroid and antiseptic misuse in Nigeria, a case series. I'll be discussing with the following outline to highlight the global problem of resistant fungal skin infections, and then discuss a case series of difficult to treat fungal skin infections in Lagos, Nigeria, and discuss possible links with topical corticosteroid and antiseptic agent use, and then give recommendations and conclusions. Fungal infections have been underestimated and neglected in healthcare, even though they affect several millions of lives globally. A recent study showed a spike in severe fungal infections has resulted in over 150 million cases annually and almost 1.7 million fatalities. The emergence of drug-resistant fungal species is especially troublesome and requires urgent attention and focus. The focus in this presentation are superficial fungal skin infections, and the most common types of superficial fungal skin infections are tinea, candidiasis, and pityriasis fascicular, and they affect the skin, hair, and/or nails of about 1 billion people globally, or even more. Tinea and candida are infectious, while pityriasis fascicular is not. They are typically not fatal, but they severely impact quality of life negatively. As only three classes of drugs are available to treat fungal skin infections, that are the azoles, the allylamines, and others like griseofulvin and cyclopirox. Drug resistance to any one of these classes is quite concerning. Drug-resistant fungal skin infections are now being reported globally, but reports from Africa are still limited. These drug-resistant fungal infections are a growing health concern worldwide, especially in lower and middle-income countries, and the World Health Organization now considers them a widespread threat. Resistant fungi reported include the Aspergillus fumigatus, Candida auris, and then the dermatophytes, the Tinea indotinea species. And the dermatophyte infections are the focus of this case series. This diagram on the right is a study by Khan et al., which was an international survey of recalcitrant and recurrent tinea in glabrous skin, and this was as a potential indicator of antifungal resistance. This study was conducted worldwide in over 35 countries, and the ones in red are countries where recalcitrant or resistant fungal infections were, or recurrent tinea infections were recorded or reported, and incidentally, in many of these cases or countries, there was a history of use of topical corticosteroids and mixed fixed combination corticosteroid creams, alongside the recurrent or recalcitrant tinea infections. Now, possible drivers of antifungal drug resistance include the overuse and misuse of antifungals. There are many skin conditions that are not fungal, but a myriad of antifungals, both oral and topical, are used. I've seen many patients who, with psoriasis, or even atopic dermatitis, that have been wrongly diagnosed with fungal infections, have been given lots of antifungals. Also, we have wrong doses of antifungals if they're given for too long or they're given for too short. And then there's the environmental and agricultural use of fungicidal agents, which are similar to those used in humans. And this, as we know with antibacterial agents, can also have a negative impact on the efficacy of the fungal agents used in humans. There are also substandard antifungal agents used where the concentration of the antifungal agent is lower than is what is actually declared, and this can also lead to or drive resistance because people are taking underdose. And then there are also the issue of widespread misuse of potent topical corticosteroids and antibiotics, which is the focus of this case series, and this has been indicated as a possible cause of antifungal resistance. The recent emergence and increase of terbinafine-resistant dermatophyte Trichophyton indotineae, formerly known as Trichophyton mentagrophytis, has been quite concerning. It's speculated to have originated in South Asia, where topical corticosteroid use and misuse is common. Now, in Nigeria and most of Africa, we also have a similar challenge with widespread topical corticosteroid misuse or abuse. And so this may also put us at risk of having such drug-resistant species. So the main issue is that most of these topical corticosteroids are widely available in the open market. You can buy them in the supermarket, you can buy them on the street and without a prescription, and they're used for almost every possible rash and even for skin lightening because people have come to acknowledge the melanoinhibitory effect of topical corticosteroids. And they are particularly sold or marketed as these triple action creams, which contain an antifungal, usually clotrimazole, an antibacterial agent, either gentamicin or neomycin, and an anti-inflammatory like clobetasol propionate or betamethasone dipropionate. Now, these are very potent topical corticosteroids, and of course, using them for long periods of time without any restriction or without any real indication, you can imagine the kind of issues that can arise from this kind of abuse. And as you can see here, this is a clobetasol propionate in this image being marketed as a skin lightening cream for all manners of skin issues. And these are examples of the topical corticosteroids and triple action creams that are readily available and affordable in the Nigerian market. Antiseptic soaps and liquid use is another common practice in Nigeria. Over about 50% of people from a recent study showed that, recent studies showed that 50% of Nigerians use antiseptic soaps and liquids to bathe every day, and they often contain agents like chloroxylenol, chlorocresol, tricloxan, and triclocarban. And the reason for use is to kill germs or prevent infections, but there are a lot of concerns about their effects or their role in antimicrobial resistance and their effect on skin microbiome disruption. Now, this slide is just to highlight and to remind us of the cutaneous and systemic adverse effects from these topical corticosteroid misuse or abuse, which we see daily in our clinics, ranging from stretch marks to dyschromia, skin atrophy, exaggerated fungal, bacterial, and viral infections, and then also systemic issues like diabetes, hypertension, renal impairment, and Cushing's syndrome. And so now I'll go into the cases in this case series. The first is a 24-year-old female undergraduate who had a 4-month history of pruritic annular erythematous and hyperpigmented plaques on the back, the groin, and the legs. She had used several triple action creams to treat herself, and she had little relief. She also had a history of use of skin lightening agents, and she used antiseptic liquids in her bath water. So we asked for a skin scraping for fungal studies, and it showed dermatophytosis. Her HIV status was negative, and she had normal glycemic levels. She was initially commenced on oral terbinafine, 250 milligrams daily, and then topical ketoconazole and wash and creamed for 4 weeks. However, after 4 weeks, the skin lesions persisted and even looked a bit worse. We then requested for a culture and sensitivity of the skin scrapings, and it cultured T. interdigitale, which was resistant to terbinafine and sensitive to itraconazole. By then, we had already empirically changed her to oral itraconazole, and so she continued on the dose, first for 3 weeks and then repeated it twice, along with sulfur ointment and to continue the topical azoles. The treatment dose had to be repeated, but the skin lesions improved and gradually cleared within 12 weeks, 3 months. The second and third cases are presented in similar manner. These were both males. One was 28-year-old man and another was a 40-year-old businessman. Incidentally, these three cases were all first seen via teledermatology consultations. So they both presented with widespread annular scaly itchy plaques all over the body for 3 to 4 months duration, and they had used many triple action creams, multiple steroid creams, antiseptics, antibiotics, oral medications, and even injections. And a lot of these um, medications were prescribed by pharmacists or general practitioners. For the 28-year-old man, he was HIV negative and the blood sugar level was normal. However, for the case 3, his fasting blood sugar and HbA1c were elevated, even though he was not previously known to be diabetic but was newly diagnosed in this consultation. Now, fungal both had fungal scrapings done, but culture and sensitivity were not done due to financial constraints, and the other person, said he couldn't find anywhere to get it done while he was, in the UAE. I don't know why, but the first case did not respond to terbinafine. We started on terbinafine, but he was not responsive. However, switched to itraconazole, and there was some slow response, but he defaulted from follow-up. And then the third case was a slow response to itraconazole, and he's still currently on treatment with some improvement. These are photographs of the case 2 and case 3 patients. The images are not very clear because they were both first seen as teledermatology consultations, and the patients took the photographs themselves. But you can see the hyperpigmented scaly annular plaques, which are quite extensive on the thighs in this patient, and in this patient on the abdomen, well demarcated annular plaques. And so there were 4 or 5 other similar cases with similar presentations, widespread annular plaques with ring-in-ring formation, ring-in-ring presentations like this pseudo-imbricata presentation, and there's a lot of erythema and hyperpigmentation and scaling. And most of these patients had to, some were started on terbinafine, others straight to itraconazole, but had repeated multiple doses of itraconazole before there was some degree of improvement in their conditions, and some we're still seeing them in the clinic, for follow-up up until now. So in the last 1 year, I saw about 9 cases of difficult to treat superficial dermatophyte infections in my clinic and also in my practice. All cases had used triple action creams, several triple action creams, which of course contain potent topical corticosteroids. Then 7 out of 9 of the cases had also used antiseptic soaps and liquids to bathe, and 4 out of 9 cases, particularly the women, were using skin lightening creams. Fungal culture and sensitivities were only done for 2 of the 9 patients because of financial constraints. Tinea incognito and tinea pseudoimbricata-like presentations are common presentations of tinea corporis in Nigeria, due to the frequent misuse or abuse of topical corticosteroids and these triple action creams. However, an emerging complication linked to this practice is now drug-resistant or difficult to treat fungal infections. And the clinical cases in this series, they strikingly resemble reported cases of tinea indotinea, that has been reported in other climes like in India and a couple of cases from around the world. However, in our environment, the unavailability and unaffordability of fungal cultures, sensitivity, and speciation facilities hinder proper documentation and confirmation of such organisms. We posit that there is a link between these topical corticosteroids and antiseptic use and antifungal resistance. Overuse of topical corticosteroids by people and even healthcare practitioners is a major problem, and these topical corticosteroids cause cutaneous immunosuppression and skin barrier damage. And combined with suboptimally dosed topical antifungals in these triple action creams, there's selection pressure that may lead to the development of resistant strains. And then, of course, antiseptics alter the skin's normal microbiome and they may favor the overgrowth of fungi by eradicating normal bacterial flora, which can then lead to the propagation of fungal overgrowth and drug resistant strains in the long run. The WHO has recognized this issue and this problem, and in 2022, the WHO Fungal Priority Pathogens List was developed, and this is like the first global effort to systematically prioritize fungal pathogens and also discuss their public health importance. And we hope that this will help in Africa because it's also meant to drive policies to strengthen global responses to fungal infection, antifungal resistance, and also address the unmet need in research and development. So some recommendations to stem the tide of this drug resistant antifungal wave that is sweeping over the world, I think there needs to be increased regulatory measures, for the prohibition or ban of the sale of potent topical potent topical corticosteroids and triple action creams in the open market and enforce prescription only for these creams. In many parts of Africa and Asia and the Middle East, you can get any steroid cream, without a prescription, and this needs to be properly tackled. There also needs to be a lot of public awareness. An awareness campaign should engage specific groups like supermarkets, pharmacies, the beauty industry, and then social media can be used to educate the public on the risks of topical corticosteroid misuse. There also needs to be healthcare practitioner training, and antimicrobial stewardship should include antifungal stewardship as well. And there needs to be more research on mycology and then the link between antiseptic soaps and liquids and the skin microbiome in the African setting and the Nigerian setting. In conclusion, resistant fungal infections are an emerging dermatological and public health concern in Nigeria as well as across the world, and the misuse of topical corticosteroids and antiseptics likely play a significant role. Species identification and antifungal susceptibility or sensitivity is a major challenge in this part of the world due to resource and infrastructure constraints. Further research is needed in this area, and we need to have studies done in Africa, in Nigeria, that identify the species that are involved in these difficult to treat fungal infections. Of course, stricter topical corticosteroid regulations and public health advocacy are very essential. I would like to thank my GLODEM mentor, Dr. Kariwa Nat, for her support and the GLODEM program in general. It's been amazing and fantastic. I'd like to appreciate my work colleagues, Dr. Ehiage Anaba and Dr. Tomi Afolabi, which we co-manage most of these cases, and I thank the patients for permitting me to share their cases. Thank you very much for listening, and I welcome comments and questions.
Good morning to everyone. My name is Sofía Villagrán. I am a dermatology resident in Pontificia Universidad Católica de Chile, and today I want to present to you about dermatology in Chile, addressing waiting list and rural access to care. So here I have a map from South America, and this long, narrow country in the west coast is Chile. And I marked the zone where Santiago de Chile is located. So, to start with my conflicts of interest, as I told you before, I am a dermatology resident in Pontificia Universidad Católica de Chile. I'm part of the group that organized Operativos Dermatuse, and also I'm a Gloderm mentee in the cohort 2024 to 2025. To start with this presentation, I would like you to imagine living in a rural area where access to dermatological care is a 400-day wait. For many communities in Chile, this is their reality. Dermatological conditions like melanoma or atopic dermatitis go untreated, not because of lack of solution, but because they lack access. This is a new draw of the map of my country where 17 million people live. Chile is a long, narrow country spanning about 4,300 kilometers from north to south, with very diverse climates and terrains. This is a photo of Santiago, the city in which I lived, that is located in the metropolitan region. In this region is where 40% of the country population resides, and also most of dermatologists. Despite this, there are very long waiting lists that in our city. And as also you may see, this is a very modern city, but this is not the reality of all my country, which is very diverse, as I will show you now. So here I have three photos from Chile. The first one in the left, this one, is from San Pedro Atacama. This is a rural community of of 11,000 people located 2 hours from their referral hospital, which is Hospital of Calama, where a dermatological service is available. The cultural relevance of San Pedro Atacama is significant, as at least 50% of population identifies as belonging to an indigenous group. Many patients from nearby villages, such as Socaire, Camar, Talare, Peine, and Toconao, are unaccustomed to leave their communities, so they don't attend to medical appointments in Calama. Secondly, we have here a photo of the Andes Mountains, which runs along the length of Chile, and often pose a challenge to access to different places. And here in the third photo, we have a photo of a Mapuche woman. Mapuche communities are indigenous people that lived in Chile prior to the arrival of Spanish and who maintain their own beliefs and culture. Here I have other photos from Chile. This one from the left is from Chiloé, which is a group of islands that are located in the south of Chile, and they require sea transport to reach the base hospital in Puerto Montt. And this photo in the bottom of this page is from Easter Island, that is also located in Chile and is really far away from the continent, and we have only a few flights a week to go to Easter Island. So, as you may see, rural areas in Chile are very geographically dispersed. So, a little bit about our health system. Well, our health system is divided through public and also private systems. This gives disparities in the access to care, but also these disparities are even more when we compare urban areas to rural regions where the dermatological care and the access to medical care is really scarce. So, what's the problem? As you may already know or noticed, we have a problem of access to care. And this is due also to the lack of dermatologists. In Chile, we have 512 dermatologists in a study done in 2022, and this gives a reason of 2.9 per 100,000 inhabitants. 64% of them concentrate in the metropolitan region, and in the public system, there are only 162 dermatologists, where 52% of them are in the metropolitan region. And the regions with lowest availability of hired hours are Antofagasta and Arica de Parinacota, with 34 hours per week. This also, this, as I told you before, gives a challenging access to dermatological care, as we have an unequal regional distribution with significant disparities between the metropolitan region and other regions. And also, we have a very limited availability of dermatological care in the northern and in the rural areas. This impacts the care of the patients because we have reduced access to specialized care and also longer waiting lists in low coverage areas. So, which is our strategy? Our team aims to bridge the gap by conducting dermatological outreach program in underserved communities. Over the past 2 years, we have conducted 3 outreach programs in remote areas, providing care to over 500 patients and reducing waiting lists by more than 70%. This initiative not only addresses the immediate needs of patients by reducing the waiting list, but also strengthens local health networks and empowers communities with education. So, here we have the 3 outreach programs we have done in the last 2 years. The first one was in San Pedro de Atacama. This is in the north from Chile, and I have already talked a little bit about it. The second one was in Pichilemu. Pichilemu is in the coast of our country, is not so far away from metropolitan region, but the base hospital from Pichilemu is more than 2 hours away. And the last one was in Coyhaique. Coyhaique is really far away from Santiago, and you cannot go by car. You have to take a plane or a ship, because in the south part of our country, we have so many islands and the land is not continuous. So the first outreach program that we done in 2023 was in San Pedro Atacama. We did consultation and skin cancer screening. Also, we did minor surgical procedures, and we did 2 educational workshops. By this, we reducted the waiting list in 190 patients, and we did 25 minor procedures. We did the same activities in Pichilemu. Here you can see some photos of our team, and we could reduce the waiting list in 90 patients, and we did 22 minor procedures. And our last outreach program that was done in November 2024 was in Coyhaique. Here we did a little bit of a change, because here we worked with the Coyhaique dermatological team, where they have 2 dermatologists, and we divided our consultations half in reducing waiting list, and the other half in patients that were already seen by a dermatologist, but they needed a second opinion, or they need to continue the treatment. In total, we attend 237 patients, and we did 30 minor procedures, and also we did 2 educational workshops for the people, one for adults and other one in a school for children. So I hope you like our project and learn a little bit more about my country and our reality. So thank you for listening, and here is my email if you want to contact me. Thank you so much. And
Good morning, ladies and gentlemen. Today, I'll be sharing about how we address various challenges in establishing most micrographic surgery in a resource-limited context. I have no conflict of interest to disclose. Malaysia is a country in Southeast Asia with a population of 33 million, and we have slightly more males than females. In terms of ethnicity, it's a mixed population with roughly 60% Malays, about 20-something% of ethnic Chinese, 12% of other native groups or Bumiputra, as well as 6% of Indians. Non-melanoma skin cancers in Malaysia are not as rare as you might think. So it's the 9th most common type of cancer for males, as well as the 10th most common type of cancer in females. And it's more frequent and with a higher rate among the Chinese population, who tend to be fairer with Fitzpatrick skin type of 3 to 4. So it's the 7th most common among males and the 8th most common type of cancer among females in the Chinese. Now, how we started was really in response to patient needs. There was a patient with a high-risk basal cell carcinoma on the nose who needed Mohs surgery. And so we suggested that she goes to either Singapore or Thailand for this surgery. And she's not from Kuala Lumpur itself. She's from a nearby town called Kajang, which is very famous for its grilled meats, as you can see, or as we call it, satay. And so because this lady couldn't afford to go elsewhere, Dr. Adrian Yong, Prof. Adrian Yong at that time, who was in our team, decided to start the service to help her. So the current scenario is that Mohs surgery is only available in 4 hospitals in the Klang Valley, which is where Kuala Lumpur is the capital city of Malaysia, and it's the major urban center in the central region of the peninsular Malaysia. And this is the data from our center between August 2022 to October 2024. We had 35 cases over 26 months, 25 were males, 10 females. Median age was 69 years with a range between 41 to 91 years. So that's 50 years range. Most of them were Chinese and with a few Caucasians, Malays, and 1 Eurasian. 33 were BCCs and only 2 were SCC. And 30 were primary skin cancers, 3 were recurrent tumors, and 2 incompletely excised lesions. 32 were on the head and neck, and only 3 on the trunk or limb. The median preoperative size was 12 millimeters, with a median final defect size of 19.5 millimeters. 21 cases were clear with 1 stage, 13 required 2 stages, and 1 case required 3 stages. 22 cases were closed with direct closures, and then 4 with island pedicle flaps, 2 nasolabial transposition flaps, 2 rhombic flaps, and 1 each of an A to T flap, bilobe flap, trippier flap, advancement flap, and 1 partial closure. 32 cases were closed by the dermatologist, and 3 cases required plastic surgery assistance. So, for instance, something on the eyelid, which required a trippier flap. How do we do Mohs surgery in our center? We perform sharp debulking followed by curettage, and then we take the Mohs layer by scoring a 2 millimeter peripheral margin, and then we score down the middle of the specimen and the surrounding edge longitudinally. And if it's larger, you might need other scoring, in vivo, and this creates tissue nicks, and then we excise it at a 45-degree angle to the desired depth. Next, the specimen is divided and the non-epidermal edges inked. We use filter paper and Petri dishes to transfer the tissue to the lab. And we have pre-printed maps of the anatomical sites for ease and convenience. And we have 3 different tissue flattening techniques that we use, mainly heat extractor flattening in the cryostat, aerosol freezing on glass slides, and sometimes we also need to do ex vivo relaxing incisions. So this is a paper from Indonesia. This is the only one I could find in the literature about adapting Mohs surgery to the limited resources in their context. So in this paper, it was published in 1988. After taking the Mohs layer, they would fix the specimen in formalin, and then they would send the specimen with the orientation to the pathologist for processing and standard paraffin margin examination. In this paper, they use horizontal sectioning of the tissue, and after 2 days, the pathologist informs the surgeon about the status of clearance. The process is repeated until the cancer-free plane is reached. And they had 17 patients over 2 years using this technique. So we can see challenges as an opportunity. So as Kobe Bryant says, everything negative, pressure, challenges is all an opportunity for me to rise. I've divided the challenges into 3 main categories, mainly education, whether it's in terms of healthcare professionals, patients, as well as payers, resources in terms of funding, equipment, location, expertise, as well as staffing, and adaptability in which we adapt to the local situation and the culture. So in terms of healthcare professionals, there really is a lack of awareness in terms of skin cancer diagnosis as well as management, in particular about Mohs micrographic surgery. And this is because there's minimal emphasis in the undergraduate and postgraduate curriculum, even in terms of your dermatology training. And there's also minimal clinical exposure in terms of dermatologic surgery and Mohs micrographic surgery. Next, you also face resistance to adopt Mohs micrographic surgery, particularly from certain teams in the hospital. And lastly, financial incentives. So the challenge is Mohs micrographic surgery isn't very lucrative. It doesn't pay a lot for the type of work that's needed. And so some people are not keen to pursue it because of that. Now, in Malay, we have a saying, tak kenal maka tak cinta, and this means you can't love what you don't know. And therefore, it's very important to raise awareness in terms of educating our colleagues, whether dermatologists or non-dermatologists or even GPs. So we have organized basic dermatological surgery workshops. We've had 3 editions so far, as well as updates on skin cancer management, which is kind of a non-surgical course, but more for diagnosis, management, and how to identify skin cancers. So this is a picture of our recent pre-congress workshop organized at the Regional Conference of Dermatology. So this was involving participants from around the Southeast Asian region. And we also organized lectures at national conferences on skin cancers as well as surgery with local as well as international speakers. This is a research article in which the authors concluded that it's actually okay to use a 3mm surgical margin for standard excision in Asians when you have pigmented basal cell carcinomas. But based on our data, I feel that there's still a role for Mohs micrographic surgery in our context. So as you can see, we had 114 BCCs treated with standard excisions between 2010 to 2023. 17.4 were high-risk subtypes and 19.1% were pigmented BCCs. We had positive margins in about 10% of the patients and about 13% close margins. And we found that the presence of high-risk BCC subtypes was associated with positive or close margins, even with standard excisions, with 4 to 6mm margins depending. And this adjusted odds ratio was 6.63. So for certain high-risk populations with this kind of subtypes, as well as the certain sites, you still would want to consider Mohs micrographic surgery. However, it's not easy to overcome resistance. And I like this quote that my mentor actually told me before, to tell these colleagues that a rising tide lifts all boats. So firstly, you can approach it from 2 angles. The evidence that Mohs micrographic surgery offers superior tumor clearance with tissue-sparing properties, and it should be considered as the gold standard surgery for high-risk types of non-melanoma skin cancers. Next is to emphasize to them that it's actually a win-win situation. So some people view Mohs micrographic surgery as a threat to their business, okay, in that sense. But you can actually tell them that, if you offer them a tumor-free hole or defect, then they can do whatever fancy or the best reconstruction possible. So whatever flap you want to do, you know that there's no cancer there and it's perfectly safe and fine to do it. So it's a win-win situation for us, for you, the reconstructing surgeon, as well as for the patient who then has the gold standard treatment. So besides that, we also need to educate our patients in terms of awareness of skin cancers. As you can see, the median duration prior to diagnosis, from when the skin cancer actually appeared and when they actually got the diagnosis for all skin cancers in our study was 12 months. For BCCs, also 12 months, SCCs shorter at 6 months. And also the awareness about most micrographic surgery isn't really high, especially for the Asian patients. So you see on the right-hand side, this is a screenshot of my patient information video that I've actually put on YouTube as well as on my website. So patients can actually view that and also discuss with their family about the treatment option and what is most micrographic surgery and what they can expect on that day and how reconstruction is done. You can also go through traditional media. We had an article in the national newspaper on sun exposure causing skin cancers, as well as through social media such as Instagram posts on Facebook. So in terms of prevention, it's also very lacking in terms in our patient population. So we had a qualitative study that showed, even among medical science students, they don't really, use protective clothing. Among traffic policemen, only 17% use sunscreen. There's more use of protective clothing, hats, and sunglasses because of their uniform. And there's a cross-sectional study among university students, which showed that sunscreen use ranged between 19.2% and 29.5%. So that's really quite low. And so a lot more needs to be done in terms of awareness of how to prevent skin cancers, both for primary prevention as well as secondary prevention, and particularly for high-risk groups such as patients with organ transplant recipients. Next, the big category is also on resources. We have a lot of limitations in terms of funding, equipment, surgical equipment such as your seagull handle, all right, as well as most ring kit, any other fancy equipment that you may need. It might not be available in a resource limited setting, as well as the laboratory might not be so accessible as compared to in the Western countries. So for instance, my lab is actually located in a different block and I need to walk there with my specimen and be careful not to drop it. Okay. In some hospitals, it's even located in a different site altogether, and the specimen needs to be transported with a courier, for instance. All right. And next, we have theater availability and location, which can be limited. So in our hospital, we can only use the theater once a week for half a day. So we need to make sure the tumor is cleared by then. Sometimes, we even take a slightly wider margin in 2 millimeters in order to make sure that, we address the time limitation. And also the location of the theater, as we mentioned. So, having to transport it to a different site from your lab. In terms of theater availability, the other problem is if you don't have enough slots for operating on different days, then like us, we can't offer slow-mos for cases of DFSBs or even MIS because we just don't have the capacity for it. So this is just a cartoon, the surgeon becomes a Superman to fly the specimen over from the theater to the lab. Next, we also lack expertise. We have not that many dermatologists, particularly in smaller towns or rural areas. So the role of the GP is quite important in terms of diagnosis and also directing the patients to the right consultant. If we don't have that many dermatologists, we have even fewer dermatologists or most surgeons. And this poses a challenge because most of them are located in the major city. We also don't have enough expertise for lab technicians, and so a lot of training needed to be done in-house. I would have loved to send them abroad to a center where they could learn, but sometimes, we don't have funding to do that, and the techs may not be keen because they have other commitments back home. We also sometimes face challenges in terms of staffing for both doctors as well as trained nurses. So this is a picture of in-house training. That's my trainee dermatologist who's learning how to take a Mohs layer. That's on-the-job hands-on learning, as well as our techs. They even came up with their own guide, handwritten in the local language, so that they can teach the more junior technicians on how to do it. So adaptability, sometimes we need to innovate when resources are not available. We need to address differences in anatomy compared to Caucasians, such as in terms of skin thickness and facial structures. We need to look at cultural norms and patient expectations. So in our country, some patients don't prefer secondary intention healing. They think it's not as good as, a doctor who stitches it back together. So it's important to tell them that you can get very good results and not do too much surgery. And you also face challenges in terms of logistics when you have to organize multidisciplinary teamwork. So say you do the Mohs surgery and another surgeon needs to do the closure. How do you book the theater listing and how do you find the slots? Things like that. So desperate times call for desperate measures, and necessity is often the mother of invention. So here we have on the left-hand side, you can buy this beautiful set of dyes, but for us, we just put it in specimen bottles. And I like to use paint brushes, but you could also use things like orange sticks or Q-tips to ink your edges. So this is a video of how you use a Presto Chill, which is a very useful piece of equipment if it's available in your lab. So we don't have cryo emitters and we don't have the Presto Chill. When we first started off, we started by using aluminum molds that we made, but we found that the base was uneven and this posed a problem when you try to get your on-face sectioning. So we improvised by using cookie cutter rings, okay, to replace your Mohs ring. And this actually works quite well if you can't afford a Mohs ring kit. However, because there isn't a standard thickness, you tend to overfill with the OCT, and then it takes slightly longer to freeze it and to make sure that the specimen can be cut. So in the end, we found this kind of perfect technique for us, which is a modification where we use the Mohs ring kit without the Presto Chill. Okay, so we use a glass slide with the Mohs ring because we don't have that circular disc. However, when you use this, because you don't have the Presto Chill, you have to remember to freeze it for longer in the cryostat. So for the small ring, which is 28 millimeters, you need 4 minutes, and the large ring, 5 minutes. So this is in London, which is an experiment done by Mr. Gabriel at the St. John's Institute. And in our setting, which is a tropical climate, you will require a longer time, which is 10 minutes for the small ring in a warmer room temperature. So just bear this in mind when you use this technique. Now, skin thickness in Asians is generally thicker because of increased dermal thickness and increased collagen content. So sometimes you might need to consider larger suture diameters for wound closure. And the Asian facial structure is also different with a wider face. Okay, so you have more increased bitemporal, bizygomatic, and bigonal width. Okay, with a wider forehead, mid face, and lower face, retrusion of certain structures. So you get a flat forehead, all right, slightly different look, a low nasal bridge with a broader nose, okay, and a retruded chin. So this leads to very interesting closure options. So we hardly get to see this being done in a Caucasian patient. So there's a patient with a BCC on the nasal tip, which we close with an island pedicle flap. We also tend to use more nasolabial transposition flaps compared to bilobe flaps when used more in the Western context. So in summary, skin cancers are not uncommon in Malaysia, particularly among fairer-skinned individuals. And when faced with limited resources, adaptability and improvisation are keys to overcoming challenges and to look to the future. I would like to acknowledge my team as well as the pathologists, plastic surgeons, and of course, my wonderful heroic lab technicians. And with that, I thank you. And if you have any questions, you can direct it to my email as below. And I hope you enjoy the rest of the conference. Thank you.
Hello, everybody. My name is Monica Fida. I'm professor of dermatology in University of Medicine of Tirana. My theme today will be referring hidradenitis and what's new. But why we discuss hidradenitis? Because the prevalence is really high. The prevalence ranges from 0.05 to up to 4.10, with the peak incidence typically occurring in the second or third decade of life. It affects either pediatric age, and we are actually visiting and treating either patients with hidradenitis suppurativa during the pediatric age, and it has a social and economic impact. Numerous comorbidities have been linked to hidradenitis, such as acne vulgaris, depression, polycystic ovary syndrome, dissecting cellulitis of the scalp, and metabolic syndrome. It is in fact challenging. Hidradenitis commonly proves to be recalcitrant to conventional treatment. How it is presented? With recurrent inflammation occurring more than 2 times during the 6 months period or 3 times during the 6 months period. In the inverse regions of the body, presenting with nodules, sinus tract, or scarring. And the pathogenesis is based, in fact, in perifollicular inflammation, lymphohistiocytic inflammation, with the obstruction of the duct of apocrine sweet gland, with keratin loading to perifollicular inflammation, dilation of the duct of gland, infection and abscess formation. Involvement of subcutaneous tissue is adjacent apocrine glands, with fibrosis followed, scarring, sinus formation. In this slide, you can notice very well how the cytokines are released. And you can notice the TNF alpha cytokines, interleukins, different types of interleukin. And this slide presents exactly what we took in consideration when we treat hidradenitis. As you see in this new publication by a group of authors, Julian Melchor, it is mentioned that 9 biomarkers on cytokines are released during the hidradenitis. And this one is really potential for utilization as diagnostic marker or development of antagonists against the specific agents for hidradenitis management. It is quite important to keep in mind that if you would like to treat hidradenitis, we have to choose a biologic treatment that affects especially just to the pathogenesis and especially to interleukin release. Risk factors of hidradenitis. It is inheritance, age 20-55 years, gender, mostly affects females. Obesity and metabolic syndrome is really a comorbidities of these patients. Smoking, follicular occlusion disorders such as acne conglobata, dissecant cellulitis, pilonidal sinus, Crohn's disease, hormonal factors, and local irritative agents that plays a role. Number of affected areas, it is sometimes really high, and the classification of Harley, it helps a lot when you start the treatment. Number of recurrences of acute disease before the week 12, high severity, no therapeutic response. And it is quite important to take in consideration that there are different syndromes that can be together with hidradenitis. And as you see here is Papage syndrome, Page syndrome, Sappho syndrome, Pass syndrome, that mostly of them, they have hidradenitis, acne, hyperostosis, synovitis, spondyloarthritis ankylopoetica, psoriatic arthritis, pyoderma gangrenosum, part of the disease and of the syndrome. Complications and clinical consequences of hidradenitis. As you see, severe scarring in the axilla, it has a potential clinical consequences. It is lymphatic obstruction leading to lymphedema, reduced mobility of the arm, growing involvement, genital lymphedema, chronic inflammation, amyloidosis, anemia, hyperproteinemia, infectious complications. And sometimes it is followed by cancer, increased risk of hematologic malignancy and squamous cell carcinoma, gluteal and perianal location, non-Hodgkin lymphoma, cutaneous lymphoma. We start the management of hidradenitis suppurativa with the first paper published by Journal of European Academy of Dermatovenerology by Zoboulis. Is the first protocol where then we followed this protocol when we treat our patients. But then after in 2019, it was another guideline by American Academy of Dermatology published by a group of authors when we take in consideration before the treat of hidradenitis suppurativa, we recommend to take in consideration the grading and classification of hidradenitis suppurativa. We take in consideration clinical performance, Hartley staging, inflammatory lesions that we count, abscesses, inflammatory lesions, and this one is a must before that you treat one patient with hidradenitis suppurativa. Consider either clinically following pain, the quality of life of these patients, and the recommendation of grading system in research studies are mentioned in different research. We mentioned dermatology life quality index, hidradenitis suppurative clinical response, hidradenitis suppurative impact assessment, and many other symptoms that we affect together to see how the improvement after the treatment it is noticed. Recommendations for screening for comorbidities is a must, in fact. So we have to review system and physical examination to screen for metabolic syndrome these patients, depression, anxiety, diabetes, and tobacco abuse. Refer patients with additional risk for diabetes such as obesity, hypertension, hyperlipidemia, acanthosis nigricans, and fasting glucose testing is a must. We screen for depression, inflammatory bowel disease, autoinflammatory syndromes, and inflammatory other disease. We recommend our patient for lifestyle modifications. We consult them for smoking cessation, screen for obesity and cancel weight loss. We recommend sometimes oral zinc supplement, but there is a weak evidence-based medicine to add in their everyday intake zinc. And insufficient evidence exists to recommend a voice of dairy, brewer yeast, vitamin D supplementation. First, Professor Zoboulis started to treat hidradenitis with adalimumab. Exactly what we saw in the pathology of this disease. And this one is the first paper published by Zoboulis in 2016, followed by many recommendations to use biologic agents and small molecules for treatment of hidradenitis suppurativa. And as you notice in this slide, adalimumab is approved for hidradenitis suppurativa. Dosing is recommended to improve disease severity and quality of life in patients with moderate to severe hidradenitis suppurativa. Infliximab is a recommendation for moderate to severe disease, especially to patients with high body mass index scores. Secukinumab is approved for hidradenitis from FDI in 2023. Ustekinumab is another use, especially if we treat patients with body mass index high and if we treat patients that has either Crohn's disease. And bimekizumab is really a promising anti-interleukin that have the inhibition effect in 17 interleukin with a dual action, 17A and 17F. And this one is newly approved from FDA. So, what are the new publications? Secukinumab in moderate to severe hidradenitis suppurativa is really a good choice for treatment of hidradenitis suppurativa. Again, hidradenitis suppurativa is treated successfully with secukinumab in patients who failed adalimumab treatment. These are two new publications referring secukinumab in the treatment of hidradenitis suppurativa. So, hidradenitis suppurativa, where we are and where we are going, actually. The group of authors, Amorella Scala and either Gabriela Fabrocini, has mentioned that bimekizumab and secukinumab are the most advanced part of protocols in clinical development showing promising results based on the extensive evidence of the treatment with anti-interleukin treatment. In this paper, published in 2023, Efficacy and Safety of Biologics and Small Molecules for Hidradenitis Suppurativa, it is emphasized that adalimumab ranked first, followed by bimekizumab in the treatment of hidradenitis suppurativa, secukinumab and secukinumab in the terms of improving clinical response, while bimekizumab shows superiority to adalimumab in dermatologic life quality index at the week 12 or 16. So this one is quite important to keep in our minds. A new paper that it is really a good one to emphasize is that new and emerging therapies for hidradenitis suppurativa. It is mentioned that bimekizumab and bermekizumab are the new preparates to treat hidradenitis suppurativa. And it is mentioned that bimekizumab demonstrates clinically meaningful, consistent improvement versus placebo in this new paper published in 2021 with a group of authors in JAMA Dermatology, when it is mentioned efficacy and safety of bimekizumab. But do we treat our patient just with preparation biologic treatment, or may we treat them either with surgical treatment? It is quite important that combined biologic treatment and surgical intervention for the treatment, it has a potential added benefits for the treatment of these patients with hidradenitis suppurativa in severe cases, moderate to severe cases. What is new actually? It is new that bimekizumab, it is launched and it is allowed by FDA this November 2024. And there are really good studies that emphasize the use of bimekizumab as a first interleukin 17-8 and interleukin 17F inhibitor for adults with moderate to severe hidradenitis suppurativa. Again, of group of authors, and as you see, there is a big group of authors from the whole Europe, emphasize that bimekizumab was well tolerated by patients with hidradenitis suppurativa and produced rapid and deep clinically meaningful responses that were maintained up to 48 weeks of the treatment of this patient. And as a conclusion, I have to mention that new knowledge of hidradenitis pathogenesis is leading to the development of new selective and effective drugs. Biologics drugs are revolutionizing hidradenitis management. It is quite important to keep in mind that biologic drugs approved for treatment of hidradenitis suppurativa are adalimumab, secukinumab, and bimekizumab, and different biologics are promising as it is bermekimab. But more data are needed to elucidate a standardized therapeutic algorithm for patients with severe hidradenitis suppurativa. And I would like to close my talk today with a big thank you for you who attended Guinea 2025. Thank you.
Bon,
Bonjour à tout le monde. Je suis le professeur Tenstedt, dermatologue, et j'ai le plaisir de vous parler des drogues dures et de ces aspects cutanés liés à ces drogues dures en question. J'ai ce plaisir qui est partagé aussi avec d'une part le docteur Dubois, qui est une assistante jeune, mais extrêmement dynamique, qui m'a aidé dans ce programme, et le docteur Deljudis de Fréjus, qui m'a aussi permis d'avoir de quelques très belles images. On va voir essentiellement des images de dermatologie liées donc aux drogues dures. Je n'ai pas de conflit d'intérêt, comme vous pouvez le voir. Alors, les drogues dures sont devenues un véritable fléau dans notre société et il n'est pas rare que même quand on se promène, on tombe sur ce genre de scènes comme vous les voyez ici. Personnellement, j'ai beaucoup travaillé comme dermatologue en milieu carcéral et ce que vous voyez là, c'est la prison dont je suis le dermatologue et pour laquelle, vous voyez, il y a un fourgon cellulaire qui part accompagné de gendarmes pour aller au tribunal. Et c'est évidemment dans les prisons qu'on peut voir pas mal de problèmes de drogue, d'une part, mais également dans la pratique de tous les jours. Et je vais vous montrer qu'il faut être très vigilant pour le problème cutané lié aux drogues. Alors, il y aura des intercalaires, non pas cette fois-ci de vieilles voitures comme je les aime, mais bien de pancartes que j'ai pris en photo dans différentes situations et qui sont assez cocasses, comme vous le verrez ici. Quand vous traversez, vous ne savez pas très bien où vous devez aller. Alors, à tout seigneur, tout honneur, je dirais que l'héroïne, qui est une invention médicale des laboratoires Bayer, fait évidemment partie des drogues dures et parmi les drogues les plus dures, et on en parle de plus en plus, bien sûr. Alors, l'héroïne, c'est une poudre en principe brune, mais qui peut être modifiée, qui vient du pavot, ici en haut à droite, qui a une formule relativement simple et qui nous vient essentiellement de l'Afghanistan et des contrées aux alentours, le Pakistan, etc. Voilà, ça c'est de l'héroïne ici en haut à gauche qui a été prise par les douaniers belges et qui vous la montre. L'héroïne est un produit qui a été employé de tout temps. Il y a divers produits qui ont été fabriqués par nos anciens, si vous voulez, et qui a servi en médecine. C'est un peu moins vrai à l'heure actuelle, qui a servi en médecine essentiellement sous forme d'opium pour soigner des douleurs importantes. Dans la pratique de tous les jours, sans parler bien sûr, il existe essentiellement trois types d'héroïne, la black tar, la noire, la blanche, comme vous voyez en bas, et la brune, comme vous avez déjà vu. Elles ne sont pas tout à fait pareilles parce qu'elles sont plus ou moins purifiées, bien sûr, et parfois coupées. L'héroïne blanche est celle qui est la plus classique à trouver sur le marché, mais les autres peuvent évidemment se retrouver, et la brune en particulier, du moins pour l'Europe. Alors voilà comment ça se passe. Vous voyez, voilà le petit attirail de l'héroïnomane. On voit une petite seringue, on voit ici un sachet qui contient quelques grammes d'héroïne, en fait même peu de grammes parce qu'il ne faut pas tellement non plus. Un petit couteau, une cuillère et un briquet bien sûr, plus une ceinture qui en général sert de garrot. Alors voilà, en pratique, voilà, une héroïnomane, c'est une dame qui se pique elle-même. Vous voyez qu'elle a déjà pas mal de cicatrices liées à ces injections, mais elle a un petit ulcère qui lui sert à cet endroit-là d'endroit pour être piqué. Alors voilà, l'héroïne, c'est le tout petit sachet qui est ici au centre de la diapositive. On met de l'héroïne dans une petite cupule. On découpe de petits carrés de filtres de cigarette. On prend une seringue, le garrot bien entendu, et on écrase l'héroïne dans la petite cupule. À l'heure actuelle, pour la petite histoire, un tiers de gramme d'héroïne coûte, en Europe du moins, à peu près 20 euros, sans même augmenter un petit peu de ces temps-ci. Vous voyez que d'héroïne en petits paquets, on retrouve une héroïne toute fine en poudre parce qu'on l'a pilée, si vous voulez, à l'aide de ce petit instrument. Elle était contenue dans ce petit sachet. Alors, une fois pilée, on rajoute de l'eau. Malheureusement, c'est parfois de l'eau du caniveau, c'est de l'eau du robinet, c'est n'importe quelle eau qui n'est bien sûr pas toujours stérile, bien entendu. On chauffe le tout ici en haut à droite, à l'aide du briquet. Voilà ce que ça devient. Il y a une espèce de jus jaune, brunâtre qui en découle. Et ce jus brunâtre, qui contient encore des impuretés d'une part ou des amas d'héroïne d'autre part, est aspiré à travers le petit morceau de filtre de cigarette dans la seringue qui va servir à injecter. Ici, vous voyez, c'est de l'eau du robinet. On peut rajouter un peu aussi de vinaigre pour avoir une meilleure dissolution si on le désire. Voilà, ici, l'héroïne est complètement absorbée, oui, qu'il ne reste plus que les plus gros morceaux dans le fond de la cupule, qui pourront d'ailleurs être réemployés dans la suite. Et puis, on referme la seringue et on est prêt à être piqué. On pique ici en général dans des veines, mais quand il n'y a plus de veines possibles, on pique directement dans des blessures qui résultent de nécrose liées aux injections elles-mêmes. L'autre drogue dure dont on parle beaucoup, et je dirais même de plus en plus parce qu'elle est certainement en extension à l'heure actuelle, c'est la fameuse cocaïne. La cocaïne ne vient pas du tout d'Afghanistan, mais elle vient essentiellement d'Amérique du Sud, de divers pays donc d'Amérique du Sud. De là, elle part soit aux États-Unis, soit en Europe, soit en Afrique, comme vous le voyez sur la diapositive à droite en bas. Elle est extraite d'une plante qui s'appelle la coca, bien sûr, et on peut s'en servir pour faire des gâteaux à la cocaïne. Je y reviendrai plus tard. C'est encore une petite molécule relativement simple, comme vous le voyez en bas de la diapositive. Là aussi, la cocaïne est employée depuis très très longtemps en médecine dite traditionnelle, pour des pastilles antiseptiques par exemple, pour des toux rebelles, autre exemple, enfin, dilués dans du coca, le vieux coca, et pour avoir à la fois les effets de la boisson Coca-Cola et de la cocaïne, bien sûr. Le fameux vin de Mariani était évidemment un vin à base de cocaïne. Cette cocaïne peut servir à faire des gâteaux, comme vous le voyez. Alors voilà comment ça se passe plus tard. Et surtout, elle est coupée, c'est-à-dire que très souvent, elle n'est pas pure à 90% ou à 90% suivant les pays, disons 90. Elle est très souvent diluée, si vous voulez, pour augmenter la masse, dans une série de médicaments que vous voyez ici sur la gauche. Et ces médicaments, par exemple la procaïne, c'est assez classique, même le paracétamol peut servir, la quinine, etc. Ces médicaments sont bien choisis, d'abord parce qu'en principe, on prend des médicaments relativement bon marché, et d'autre part, des médicaments qui ont le même goût que la cocaïne pour que les futurs utilisateurs ne sachent pas facilement si elle a été coupée ou non. Comme vous le voyez, cette cocaïne envahit non seulement la Belgique, la Wallonie, mais le monde entier, bien entendu, c'est évident. La prise en général se fait en la sniffant, donc en l'aspirant par le nez. Voici ce qu'on appelle des rails de cocaïne, comme vous voyez ici. Et ici, à l'aide d'un billet de 50 euros, comme vous le voyez, pour sniffer dans le nez. Mais on l'emploie de plus en plus aussi en injection, exactement comme l'héroïne, ou parfois en combinaison avec l'héroïne. Alors, passons directement à la dermatologie, ce que vous devez reconnaître, que vous devez voir, quand on ne vous dit pas, bien sûr, ce qui est la plupart du temps vrai, que les personnes se droguent soit à l'héroïne, soit à la cocaïne, soit au mélange des deux, ou à d'autres drogues dures d'ailleurs, bien sûr. Au tout début, on voit simplement de petits nodules aux endroits d'injection, bien entendu. Le premier endroit d'injection que les personnes utilisent, c'est évidemment le pli du coude, où on peut très facilement voir très bien les veines. Mais cette drogue, cocaïne ou héroïne, peut être injectée en d'autres endroits et faire des petits ulcères, comme ceci, ou de plus grands ulcères, comme ceci, on y reviendra bien sûr. Et je vous demande dans ces 4 photos, c'est un quiz si vous voulez, lesquelles correspondent à de la cocaïne ou à de l'héroïne. Vous pourriez me dire peut-être bien celle-ci parce que c'est un endroit classique. Ici, c'est déjà plus bizarre, mais pourquoi pas, près des organes génitaux. Ici, une ulcération un peu superficielle, et là, une ulcération visiblement beaucoup plus profonde. Je vous montre un cinquième cas. Voilà un cas d'une lésion livédoïde, une ancienne cicatrice ici et une petite ulcération dans dessous. Alors, drogue dure ou non? Ben, la réponse est facile, c'est chaque fois. Ces 5 cas que je vous ai montrés ici correspondent tous à des drogues dures, quelles qu'elles soient d'ailleurs. Je vais y revenir tout de suite. Voilà un genre de pancarte ou de panneau, comme vous voulez, qu'on peut trouver en Belgique et qui est plutôt relativement curieux. Alors, complications aiguës, on va revenir au cas que vous avez vu en montrant d'autres. Ça, c'est une lésion extrêmement caractéristique, non seulement à cause de l'endroit, c'est le pli du coude, mais également parce qu'il existe une pustule blanchâtre à l'expression, si vous voulez, témoignage d'une infection ou presque une surinfection, c'est comme on veut. Ici, ça c'est la photo que je vous ai montrée comme premier cas clinique de quiz. C'est ce qu'on appelle une injection marks, donc une marque d'injection. L'endroit est évidemment caractéristique et bien sûr, il s'en découle des nodules qui vont pouvoir rester quand même plusieurs semaines en place. Parfois, ces nodules sont tout petits, c'est un autre exemple, et déjà une petite cicatrice qui survient là. Il est évident que tout nodule ou toute cicatrice à cet endroit-là n'est pas nécessairement lié à une injection de drogue dure, mais peut très bien survenir après une injection n'importe laquelle dans une veine pour un produit X qu'on aurait ajouté à l'hôpital ou ailleurs d'ailleurs. Donc c'est un signe qu'il faut regarder, mais qui n'est pas pathognomonique. Ceci est déjà, la petite cicatrice en haut à gauche est déjà plus particulière parce qu'elle s'éloigne largement de l'endroit le plus classique pour les veines. Mais d'autres endroits, bien sûr, sont possibles. Voilà encore. C'est tout petit, il y a une petite pustule qui vient et il y a un petit édème avec un érythème autour de la pustule qui était l'endroit d'injection. Beaucoup d'autres endroits peuvent être utilisés et ça c'est déjà plus particulier, mais ce n'est pas exceptionnel. Ce sont les espaces interdigitaux ici qui servent de lieu de réception de l'injection. Alors, ces infections, dont je vous ai montré quelques exemples localisés, bien sûr, peuvent être des infections liées à des champignons, à des bactéries, bien sûr, qu'elles soient anaérobies ou aérobies. Le matériel lui-même peut être contaminé, surtout qu'il est remployé très souvent, plusieurs fois, et je ne vous parle pas de l'eau qui sert à diluer la drogue, mais surtout aussi, et vous voyez qu'il y a ces fameux autres produits qu'on ajoute peuvent également être responsables de ces infections. Le solvant est évidemment essentiel. Je ne vous ai pas dit que quelques gouttes de citron aussi facilitent la dissolution de la drogue, qu'elle soit l'une ou l'autre d'ailleurs. Si elle est favorisée par tout cela, il est évident qu'elle est favorisée avant tout par une absence d'asepsie lors des injections, comme vous pouvez imaginer. Et il faut reconnaître que l'hygiène est généralement peu importante chez ces personnes. Mais ça, c'est évidemment à voir au cas par cas. On peut évidemment, et ça je vous le conseille aussi, c'est faire des frottis dès que vous voyez une pustule liée à des injections ou non d'ailleurs. Et on peut retrouver, comme vous le voyez, toute une série de germes aérobies, anaérobies, ainsi que des levures. Il est évident qu'on en verra moins s'il y a moins s'il y a moins d'antisepsie, plus d'antisepsie, pardon, bien sûr. L'association d'héroïne et de cocaïne favorise les infections et les injections intradermiques, bien sûr, directes, évidemment aussi. D'autres exemples, comme vous voyez, ici, l'infection n'est pas uniquement liée au petit nodule, mais s'étend, comme vous le voyez ici à droite aussi, ou en bas à droite, avec une énorme cellulite qui est survenue dans les jours qui ont suivi l'injection en question. Et tous les endroits, et toujours les endroits les plus classiques, je vous ai dit, le pliant du coude, voilà encore un exemple à plus fort grossissement. Il est évident qu'ici, dans ce cas-ci, par exemple, il faudra procéder à une petite incision et récolter le liquide pour avoir une certitude quant à la cause qui peut, je le rappelle, être à la fois bactérienne ou parfois aussi liée à des champignons ou à des levures, c'est comme on veut. Le plus fort grossissement, de ce que je vous ai montré plus tard, c'est ici qu'il faudra prélever avec un coton-tige tout simplement pour la recherche du germe en question. Mais les cliniques sont parfois moins nettes, plus importantes. Vous voyez ici, on déborde largement du pliant du coude. Ici, l'injection s'est faite au niveau de l'avant-bras. Ici, au niveau du bras. Là encore, au niveau du bras. Autrement dit, quand on voit des petites lésions, même plus ou moins grandes, qui se développent de manière bizarre à un endroit entre guillemets bizarre, mais souvent un endroit qu'on atteint facilement soi-même. Ce ne sont pas des lésions qu'on trouve dans le dos, bien entendu, parce que les personnes ne se piquent jamais à cet endroit-là. Ce serait assez compliqué. Voilà la première photo que je vous ai montrée aussi, un fort grossissement, mais vous voyez qu'il y a des injections qui peuvent se trouver en d'autres endroits, comme vous le voyez ici de manière très nette. Attention à ce cas que je vous ai montré déjà dans le quiz. Ici, il s'agit d'une ulcération indiscutable, un peu de bétadine autour, et cette ulcération est visiblement profonde. Non seulement elle est profonde, mais elle est dite un bouchon de champagne, c'est-à-dire qu'elle s'étend à l'intérieur beaucoup plus largement que ce qu'on voit à l'extérieur. Quand vous voyez ce genre de clinique, vous soupçonnez évidemment une injection de drogue, toujours faire une radiographie, éventuellement une échographie, mais une radiographie comme ici, où on voit très bien qu'il existe une fistule, là, qui part de la peau avec l'inflammation ici, et qui va jusqu'à l'os avec une inflammation périostée, sous-périostée, de cet endroit. C'est évident que là, un acte chirurgical va devenir absolument indispensable. Une photo que je vous ai déjà montrée, voilà ici donc des différents endroits également possibles d'injection. Ici, les organes génitaux, la verge en particulier, c'est très classique à cause des veines dorsales du pénis. Et puis, d'autres injections plus haut, à la recherche ici de la veine fémorale et ici en plein milieu du tissu graisseux. Voilà le fort grossissement au niveau de la verge. Je vous ai également montré cette photo qui correspond également à une injection pardon, d'une drogue dure, héroïne ou cocaïne, ici c'était de l'héroïne, avec un aspect très particulier qui est cet aspect livédoïde que vous voyez ici. Et on voit déjà qu'il y a une intervention, bien indiscutablement, au-dessus à droite, qui correspond en fait à un placard d'exérèse tout à fait identique. Cette dermite livédoïde ne disparaissant pas, il y a une petite intervention qui a été faite à cet endroit. Et puis on voit des différentes cliniques, parfois particulières, avec des ulcérations qui prennent diverses formes. C'est probablement ici une ulcération qui survient lors d'une injection d'héroïne à cet endroit-là. Regardez bien aussi dans ce cas-ci, une grosse nécrose, il y a une injection toujours, et ce grand placard périnécrose, c'est cette allure très violacée, et on y reviendra dans la suite bien sûr. Ici, une injection au niveau d'une main, vous voyez, qui a mal tourné, qui a fait une nécrose. Et il y avait déjà eu une nécrose antérieurement au niveau du poignet, comme vous le voyez. Donc, la clinique est assez diverse et très intéressante parce qu'elle est vraiment diverse. Et comme vous voyez, quand on voit une ulcération, surtout chez quelqu'un qui est jeune, qui est en bonne santé, on n'a pas de cause a priori, toujours penser à se documenter s'il n'y a pas eu des injections d'une drogue dure, bien sûr, à ces endroits-là. Encore un exemple ici, une injection au niveau des veines du pubis chez cette jeune dame qui a fait développer une très grosse nécrose, comme vous voyez ici. Alors, il est possible aussi qu'il y ait une partie d'injection intra-artérielle. Ça n'est pas du tout impossible en voyant ce placard livédoïde très, très suggestif chez elle. Les choses peuvent se compliquer largement avec ici une nécrose du pouce, de l'évidence ténare et évidemment des dégâts au niveau des artères, comme vous le voyez très bien ici. L'artère ici est complètement bouchée, comme vous le voyez, du côté du pouce, bien entendu. L'artère radiale, bien sûr. Et puis, on peut voir des choses beaucoup plus dramatiques qui vont devoir nécessiter, évidemment, une très probable amputation. On peut aussi voir des fascites nécrosantes. Ici, c'est une fascite nécrosante qui est déjà en train de se réépithélialiser. On a fait des greffes, etc. Vous voyez qu'elle peut être extrêmement importante et la nécessité, bien entendu, pour sauver la vie du patient, une hospitalisation avec une exérèse de tous les tissus atteints, comme on doit se faire en bonne pratique d'une fascite nécrosante. Vous voyez qu'en Belgique, les personnes qui s'occupent du marquage des passages pour piétons sont parfois distraits. Il existe aussi des complications chroniques à toutes ces injections, mais ces complications chroniques sont très intéressantes à bien regarder. Vous allez voir d'une clinique, et je pense que là aussi, ou là encore plus, la clinique doit être extrêmement fine quand on regarde nos patients. Regardez bien, je vais voir une photo, deux photos, trois photos. Je vais poser les mêmes questions. Est-ce lié à des drogues, oui ou non? Drogue dure, son temps. Voilà trois cas. En voilà quatre autres. Une main, une jambe, deux jambes même, et enfin, de nouveau des mains. Le quiz, je vous réponds tout de suite, à nouveau, c'est chaque fois oui. Tous les cas que vous avez vus sont liés à des injections. Vous voyez que l'association de ces plaques peut être parfois bizarre. Alors ici, il faut regarder de tout près, et ça peut être très intéressant, et quand on a des suspicions d'injection de drogue, regardez les endroits facilement accessibles, dos des mains par exemple. Et on peut trouver assez facilement de toutes petites lésions, cicatricielles pour la plupart du temps, témoignages d'anciennes injections, parfois pas très très vieilles d'ailleurs, qui sont ici de petits placards ronds, un peu rougeâtres. Ça peut aussi être parfois des toutes petites lésions cicatricielles blanches, comme vous le voyez ici, et la même chose, bien entendu. Ce qui est un signe beaucoup plus pathognomonique, pardon, c'est ceci, des petits placards brunâtres, pigmentation post-inflammatoire, bien entendu, accompagnés de petites lésions blanchâtres légèrement cicatricielles. Donc cette cohabitation de ces deux types de lésions, vous voyez très très bien, sont suspectes d'avoir eu des injections intradermiques, bien sûr. Ici, encore quelqu'un qui a très bien cicatrisé, mais avec des petites lésions blanchâtres, un peu spécifiques, pas toujours bien arrondies d'ailleurs. Ici, encore en plein milieu de la diapositive. Et ici, sur la droite, on les voit très bien. Ici, plus caractéristique encore, bien sûr, un placard blanchâtre lié à une cicatrisation et une petite inflammation en même temps. C'est presque un peu pseudo-post-varicelle, si on veut. Ces petites lésions peuvent devenir largement brunâtres par pigmentation post-inflammatoire et être combinées à des ulcérations plus ou moins chroniques ou en train de cicatriser. Mais il est évident que l'hygiène de cette personne en particulier était tout à fait déplorable, comme vous pouvez l'imaginer. Un plus fort grossissement, un mélange d'atrophie, de pigmentation brunâtre, c'est suspect évidemment. Autre exemple ici à gauche, c'est cette personne qui a un tatouage. Et comme vous voyez ici, une petite lésion arrondie, plus ou moins blanchâtre, plus ou moins brunâtre, c'est comme on veut. Assez piégeux ceci, ce sont une juxtaposition de ces lésions brunâtres post-inflammatoires, bien entendu, qui miment une dermatite ocre par exemple, mais qui ne sont pas du tout dans le contexte d'une grande ulcération veineuse, comme on le voit la plupart du temps dans les dermatites ocre liées à une insuffisance veineuse et des ulcérations. Et ce n'est d'ailleurs pas l'endroit non plus classique de la dermatite ocre. Encore que. Quand il y a évidemment cette pseudo-dermatite ocre accompagnée de lésions à la fois blanchâtres et brunâtres, il faut certainement y penser. Le deuxième cas que je vous ai montré, c'est ceci. Et ça, c'est uniquement lié à des injections, et c'est ce qu'on appelle les fameux tracts. Les tracts, les rails en anglais, des lésions linéaires qui correspondent à des micro-phlébites, si on veut, qui sont linéaires toujours et qui sont liées à des endroits d'injection au niveau des veines où il y a eu du produit qui s'est répandu en paraveineux. Ici, vous voyez encore des tracts, toujours des tracts, lésions linéaires chez ce prisonnier, lésions linéaires, une véritable phlébite si on veut, avec les points d'injection qui se situent ici au-dessus. Ici encore toujours des tracts. Quand on a vu quelques-uns, on ne peut absolument pas les rater. Et puis, il peut y avoir des lésions beaucoup plus importantes, comme vous le verrez ici, avec des genres dites chroniques d'injection, avec des mélanges d'ulcération, de cicatrisation, de nodules, bref, des lésions très bigarrées, comme vous voyez ici. Et à nouveau, comme je vous ai montré lors de toute première diapositive, la personne qui s'injectait devant vous, et des ulcérations que les personnes ne veulent pas nécessairement voir guérir parce qu'elles servent de réceptacle aux futures injections, comme on peut l'imaginer, parce qu'à ces endroits-là, la douleur est pratiquement nulle, puisque vous n'avez tous les petits nerfs qui étaient présents au niveau de la peau ont été détruits. Donc des mélanges bigarrés, c'est assez pathognomonique. Voici encore des séquelles beaucoup plus importantes d'injecteurs chroniques avec des mains gonflées par problème lymphatique. Et ces fameuses mains qui sont gonflées, qu'on appelle en anglais les puffy hands, les mains gonflées. Et ça, c'est aussi relativement pathognomonique d'injection de drogue dure, avec des doigts qui deviennent triangularisés, comme on le voit ici en bas à gauche, et des séquelles d'injection, bien entendu. Ces séquelles d'injection ne sont pas toujours présentes, vous le verrez plus tard. Encore des exemples. Ici, un autre exemple de puffy hands, avec des mains gonflées, parce que les lymphatiques ont été en partie détruits. Ici, des mains gonflées et des ulcérations bizarres qui ne guérissent pas et qui ne montrent pas leur nom, si on veut, ou leur origine plutôt. Encore ici, un doigt très triangularisé, ici l'annulaire droit de la personne, et des mains gonflées, donc des puffy hands, tout à fait caractéristiques. Et encore d'autres, bien entendu, et je remercie d'ailleurs les quelques personnes qui m'ont permis d'avoir ces photos très, très typiques. Voilà encore, les mains gonflées peuvent évidemment atteindre les faces palmaires, comme ici, comme là, ou ici encore. Et quand on a vu quelques-unes, il est évident qu'on ne peut pratiquement plus les rater si on veut. Puffy hands. Alors bien sûr, ces puffy hands peuvent bien entendu s'accompagner d'ulcérations qui sont des ulcérations soit liées à l'édème lui-même, soit liées bien sûr à des endroits d'injection. À nouveau, remarquez la triangularisation des doigts, très 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 caractéristique ici, sur le majeur de cette main gauche. Encore voilà, vous voyez qu'on peut en montrer comme ça pas mal. Ces puffy hands peuvent devenir des puffy feet, liés aussi à des injections avec un signe de Steiner que vous voyez ici en bas. Et bien entendu, ça c'est tout à fait spécifique de la cocaïne, c'est cette interruption ici de la cloison nasale avec des nécroses à cet endroit-là, de la columelle par exemple. Et il y a eu une tentative de fermeture qui a échoué, comme vous le voyez ici. Mais donc, les ORL connaissent bien ces lésions muqueuses nasales liées à de la cocaïne qui est sniffée, évidemment, et qui donc est assez irritante. Pour les muqueuses nasales, vous voyez ça, on ne sait pas très bien où on doit aller. Alors, les infections maintenant systémiques, parce que on a vu surtout des problèmes d'infection locale ou relativement localisées, mais les infections systémiques, les infections pardon, systémiques peuvent être très diverses. Ici, une jambe très suspecte d'être une jambe des ulcérations liées à des injections de cocaïne, et puis des nécroses, comme vous voyez ici, très particulières de l'hélix, et tout ceci correspond avec l'aspect livédoïde ici, à une vasculite, et donc une inflammation, puis une obstruction des divers vaisseaux. Et c'est typique d'un mélange de cocaïne avec du lévamisole. Il faut savoir que le lévamisole est un produit qui a été employé comme anti-élevant il y a pas mal de temps, et puis comme anti-inflammatoire, peut, quand il est injecté, bien sûr, il est lié à la cocaïne parce qu'il augmente le volume de la poudre de cocaïne, peut donner lieu à ce type de complications tout à fait particulières. Des septicémies peuvent se voir, bien sûr, avec des petites lésions à distance des points d'injection. Ici, une septicémie à streptocoque, comme vous pouvez l'imaginer, avec ces petits points rouges très particuliers. Encore d'autres, bien sûr, toujours des septicémies à germe. Ici, c'était aussi une septicémie à germe gram positif. Voilà encore. Et puis des abcès à distance, bien entendu, pas du tout à des endroits d'injection, des abcédations ici. On voit très très bien au niveau du sternum, bien entendu. Et alors, d'autres lésions relativement pathognomoniques, ce sont des pseudo-verneuils, dit-on. En fait, ce n'est pas du tout des verneuils, c'est une infection systémique liée à une mycose et à du candida, en général le candida albicans d'ailleurs, qui a été injecté au niveau des veines et qui, pour une question très particulière, se retrouve soit au niveau des aisselles, comme vous le voyez ici, avec des pustules qui à l'examen écologique seront très très positives, ou à des pustules également possibles au niveau du cuir chevelu. Les deux endroits où on les voit essentiellement. C'est ici des séquelles de pustulose candidosique liées à des injections de cocaïne. Alors évidemment, je ne vous parlerai pas ou très peu des effets psychologiques, psychogènes de ces drogues. Vous savez comme moi que l'héroïne est plutôt une drogue qui apaise, qui détend, alors que la cocaïne est plutôt une drogue qui excite et qui rend le sommeil relativement inutile. C'est ce qui explique que dans le milieu de la nuit, on en rencontre relativement souvent. Je terminerai par quelques lésions aussi, qui sont aussi des lésions séquelaires ici à droite, mais vous voyez qu'il y a plus que des séquelles, il y a des lésions linéaires ici à gauche de votre écran, qui montrent que cette personne a fait une tentative de suicide liée à une overdose de cocaïne d'ailleurs. En ce qui concerne le dépistage, pour ceux qui peuvent s'en procurer, c'est extrêmement simple. On a maintenant à notre disposition des tests qu'on appelle Ratisbonne, qui permettent de détecter toute une série de drogues simplement en récoltant un peu d'urine. Et on a la détection dans les minutes qui suivent, le fait qu'on trempe ces petites languettes dans de l'urine et vous pouvez détecter la buprenorphine, les amphétamines, la cocaïne, l'héroïne, le cannabis, les benzodiazépines, etc. Il y a toute une série de tests Ratisbonne différents. N'insisterai pas, mais donc c'est sur Internet, vous trouvez ça relativement facilement. Et dans les consultations, et ça peut être extrêmement utile pour faire des dépistages à la minute. Ici, par exemple, je vous montre ici un test positif à la méthadone. Vous voyez qu'ici, il n'y a pas de petite barre rouge alors qu'il les faut partout. C'est l'inverse des tests pour le Covid, par exemple. Enfin, ça, le mode d'emploi est bien indiqué. Voilà ce que je voulais vous dire. Sur ce, vous voyez que même Tintin a failli être drogué à la cocaïne ou à l'héroïne, mais ça, l'histoire ne le dit pas. Et je vous remercie de votre attention.
Greetings. This is Dr. Ina Sataya, Professor of Dermatology and Immunology at Ain Shams University, Cairo, Egypt. I'm also consultant dermatologist in Saha, Abu Dhabi, UAE. Today, my talk is about pseudo-knuckle pads, repeated trauma, and beyond. I don't have any conflict of interest. My objective is to present a case of pseudo-knuckle pads and the approach to diagnosis, to present the historical background of such cases, to review clinical aspects and previous reports of similar conditions, to discuss the underlying pathology beyond the skin, and to highlight the role of dermatologists in management of such cases. My case report is about a 16-year-old female patient referred for recalcitrant progressive finger lesions of 8 years duration. She is a daughter of non-consanguineous parents, the third of 3 siblings with a brother and a sister, with no family history of chronic skin condition or any other chronic systemic or immunological condition. She had previous treatment with topical emollients, keratolytics, corticosteroids, with mild transient improvement. Here are the lesions. They are erythematous, asymmetrical, thickened, lichenified skin plaques overlying the knuckles of the right index, the middle finger, as well as the distal phalanx of the left index finger, with left index proximal nail fold chronic paronychia and longitudinal nail fissure. Dermoscopy showed erythematous skin plaques overlying knuckles with irregular dotted vessels, tiny scales, and minute excoriations. Previous diagnosis and differential diagnosis included knuckle pads, localized erythrokeratoderma, psoriasis, and eczema. Actually, the patient was sent to me for skin biopsy. Both parents and patient denied any abnormal repetitive behavior at first. However, after several consultations and upon questioning in privacy, only the patient was with me, the patient confessed that she repeatedly bites her skin. This longitudinal nail fissure, which highlighted to me that it could be due to biting, because it seems that it is due to sliding of the teeth onto the nail to the nail fold. So diagnosis is pseudoknuckle pads due to dermatodaxia or body-focused repetitive behavior of recurrent skin biting. After the condition was explained to the patient, she consciously refrained from biting her knuckles with improvement within few weeks. So dermatodaxia describes the humans who bite their skin. Previously used less appropriate designations included chewing pads, wolf biter, and dermatophagy. Dermatodaxia is a kind of body-focused repetitive behavior disorder and is classified in category of obsessive compulsive and related disorders. People who bite their skin may concurrently have other related disorders such as dermatotillomania, trichotillomania, and or onychophagia. In historical background, Dr. Sulzberger and Zaidens called attention to compulsive movement associated cutaneous lesions. They commented not only that lesions resulting from compulsive movements can occur in any sites and are due to biting, chewing, or sucking, but also they have seen skin lesions from compulsive movements or tics on almost every part of the skin from toes to crown. In 1997, Scott and Scott introduced the term of dermatophagia to describe the conscious or subconscious compulsion or habit of biting the own skin. They consider this condition analogous to other self-mutilating disorders such as hair pulling and nail biting. In 2005, Metropolis and Norton discouraged the term of dermatophagia, which implies consumption of the skin. By searching Greek dictionaries, they discovered that dermato refers to the skin and daxia refers to biting, so they suggested the term of dermatodaxia. Dr. Weidman and the 72nd annual meeting of American Dermatological Association in Colorado in 1952 specially stated that as the wolf biter, this designation was given by Dr. Butterworth, a consultant to a state institution for feeble-minded. There he found many of inmates bite their knuckles. At one of other society meetings, Dr. Butterworth suggested that diagnosis for a patient who wasn't an inmate of an institution. So it is not only for patients with mental retardation, it can be in other patients as well. In 1976, Michael and Lewig described chewing pads. Chewing or sucking resulting in a pad-like thickening localized to the affected area, commonly the knuckles. So it's considered as a variant of knuckle pads, and it's better to call it pseudo-knuckle pads. They were described in young men who had a tick-like habit of sucking or biting on dorsal proximal joints of the thumb and fingers while concentrating or doing their schoolwork. After the condition was explained, one patient consciously refrained from biting knuckles with improvement, while psychotherapy was recommended in another patient who declined to have it. Ulina in 2005 commented that chewing pads could be observed in obsessive-compulsive computer and video game users. From mechanical factors of repetitive biting, chewing, or sucking of the skin, which thickens and become rough. However, lesions may completely resolve if the causative behavior was modified or discontinued. Dr. Butterworth mentioned that salesmen occasionally bite their knuckles, commonly the proximal interphalangeal joint of the index finger of the left hand, when they stop at the traffic lights. He also described similar lesions over the interphalangeal joint of his own thumb due to chewing at board meetings when concentrating. It persisted even after persuasion to stop. Dermatodaxia is asymptomatic, usually unilateral, solitary, lichenified, callus-like, thick nodules with or without hyperpigmentation and hypertrichosis. Severe biting results in ulcers and infections. Bilateral involvement or multiple biting sites or both may occur. The most frequently bitten sites were the upper extremities, particularly the extensor forearm, dorsal hands, and fingers, with a predilection of the dorsal fingers. Skin biting has also been observed on knuckle of the thumbs. Location of the skin biting is variable, either involving skin between knuckles or overlying knuckles. Some individuals demonstrated biting of their feet and ankles, fingertips, or nail folds. In previous reports, a 15-year Middle Eastern boy with otherwise good behavior and satisfactory school performance was reported with dermatodaxia resulting in callus-like lesion, with thick skin-colored discoidal plaques on the knuckle prominence of both hands of several months duration. When there was no improvement after 3 months of keratolytics, the boy's father provided additional history that his son had intermittent habit of biting his knuckles. After the cause of the condition was explained, the boy attempted to stop biting of his knuckles and had almost given up dermatodaxia with improvement. Another 16-year-old boy presented with chronic bilateral dark brown, slowly increasing asymptomatic hyperkeratotic rough scaly plaques of 1 year duration on the dorsal proximal index fingers between the metacarpopharyngeal joints and the proximal interphalangeal joints. Actually, the boy's father had been killed by militants 1 year before. Within a short period of time, his behavior changed and he began to repeatedly bite and chew both affected sides after this psychological trauma. Management included topical agents, keratolytic and moisturizer, and psychiatry referral. From May 2002 to February 2018, a study was conducted in Psychocutaneous Clinic in Middleton to evaluate referring and final diagnosis. A total of 808 individuals were evaluated. Skin picking disorder was the most frequent final diagnosis in 52% of the referrals. Some of the skin pickers had two or more concurrent final diagnoses. For example, either trichotillomania or onychotillomania were simultaneously present, and there was one person who had not only picked at the skin, but also had both hair and nail trichotillomania and onychotillomania. In 2018, a big study included 4,435 undergraduate university students from June 2014 to May 2017 for body-focused repetitive behaviors, including cheek biting, hair pulling, nail biting, skin picking, and teeth grinding. They discovered that 72% had body-focused repetitive behavior, but they were subclinical in about 60% of cases. 47% of patients had one body-focused repetitive behavior, while about 35% had two, and 15% had three, and 3% had four. Only 14 students had five body-focused repetitive behaviors, and only one student had all the six. Skin biting was subclinical in 2.4% of students, or clinical in 0.5% of the participants. What about the management? Physical modalities, behavior modifications, and or pharmacologic agents may be used. However, many individuals with dermatodaxia are not only aware that their cutaneous lesions are caused by their skin biting, but also they don't want to discuss the possibility of initiating any intervention that might change or stop their skin biting. Maybe it relieves their anxiety also. Physical modalities are those that incorporate an agent such as band-aid, paper tape, or glove to physically cover the affected skin site. Hence, by protecting the affected area, the individual is not able to bite the site. Protective gloves was referred as protecting little and adolescent youth or play hands can be created either using an orthosis for either affected finger or for all fingers of the entire glove using thermoplastics. The play hands or the protective handwear was considered for children with cerebral palsy to prevent self-mutilating behavior. However, they could be also useful for patients with dermatodaxia localized to the hands and fingers. But if the patient is aware of this condition and he's not willing to do so, so it's not effective. Several behavior modifications are used in patients with obsessive compulsive and related disorders, including body focused repetitive behavior, such as the dermatodaxia, with variable rates of success, such as decoupling, habit reversal training, and hypnosis. In decoupling, the user is instructed to modify the original dysfunctional behavior path by performing a counter movement shortly before completing the self-injurious behavior. Moritz in 2020 reported a 50-year man who had not only dermatodaxia but also pathological skin picking and onychophagia since early childhood. At the age of 40 years, his nail biting was considerably reduced after he was treated by decoupling. Essentially, he would perform the exercise or physical movement to generate a conscious irritation just before completing the undesired behavior. However, he would still bite and pick at the skin on his fingertips and nail folds. Therefore, a revised decoupling protocol involving exercises that incorporated both the imaginal and behavioral sequence was initiated that resulted in elimination of both his skin biting and picking. So in decoupling, if the patient is willing to do the skin biting or the dermatodaxia behavior, he is instructed to clench his fist or to sit over his hand or to interlock his fingers. In the revised decoupling protocol, the patient will imagine that he is going to do the dermatodaxia act, and then he will do the decoupling act by also same clenching or sitting over the hand or interlocking the fingers. Pharmacotherapy is also a treatment option for patients with debilitating body focused repetitive behavior. Some of the medications include SSRIs. However, in some countries, prescription of psychotropic drugs is only for psychiatrists. N-acetylcysteine is a glutamate modulator showing promising results in controlling body focused repetitive behaviors, and this can be prescribed by all physicians. So in conclusion, dermatodaxia is habitual biting of the skin without consuming it. It is an underreported psychocutaneous disorder that may be commonly seen particularly among teenagers and undergraduates. A localized variant of dermatodaxia is referred to as chewing pads or pseudoknuckle pads, are restricted to the knuckles and morphologically mimics knuckle pads. It is one of the obsessive compulsive related disorders and body focus related behaviors, which include cheek biting, hair pulling, nail biting, skin picking, and teeth grinding. Individuals with dermatodaxia may concurrently have other body focused repetitive behavior related conditions affecting their hair, nails, and skin. Many patients are likely aware that the lesions were created by their own biting, but they don't want to consider any potential therapeutic interventions. It is mandatory to raise public and medical awareness about this condition, particularly among dermatologists. Dermatologists can recommend physical modalities, behavior modifications, and N-acetylcysteine referral for further psychiatric evaluation is recommended in case of debilitating dermatodaxia and or other suspected psychiatric disorders. Just before I prepare this presentation, I encounter another patient, another story. These are my references, and thank you.
Hello, everyone. I am happy to present my talk in this international conference. I am Professor Mahsoun Zalimi from Faculty of Medicine, University of Kufa, Najaf, Iraq. I would like to present a talk of laser-assisted transepidermal drug delivery in dermatology. I have no conflict of interest for this talk. Direct application to the skin remain a favorable method for treatment compared to systemic therapy. Stratum corneum found to be the toughest barrier to chemical agents.
Greetings. This is Dr. Ina Sataya,